as someone on the medical side and then somebody who's done IVF, I feel like it feels overwhelming. And so having these webinars and really understanding what you're getting into, and then, hopefully that's going to scale back and take away some of the anxiety and some of the stress related to it, because you want to take your medical care into your own hands and have a good knowledge of it. And that's certainly what our job is. And that's what my job is here tonight. And that's what we're about at Kindbody, to help you guys with that. So goal tonight, talk about IVF. And then if we, digress a little bit, that's fine. We can always talk about a couple other things too, but we'll try to get through everything. All right, so I'm like Sydney said, I'm Dr. MacKenzie Purdy. I'm located in the St. Louis region. I grew up in Missouri, but I'm also going to be covering the Arkansas group and going down to Bentonville. So excited! I'm actually going down next week to see the clinic and to work with all the staff, and we're getting everything ready because that clinic is amazing down there. So once again, this is going to be focused on kind of our St. Louis region and focused on the Arkansas region, and that's where I'm mostly based. But we have clinics all throughout the United States, which is wonderful, and we can find you a clinic no matter where you are to get the right care that you need and make sure that everybody's getting taken care of. So if you want, once again, you can DM me. I'm on Instagram. Feel free to send me a question. I try to get to pretty much everybody. All right. So our mission at Kindbody, which I kind of said earlier, is our goal is that we're trying to be unique, but we certainly, our goal is to offer standard of care, which is to provide really good access and make sure everyone's taken care of to a really high standard. And our, what I think sets us apart a little bit is that we have the ability to have more clinics. We're able to do a lot of things in-house, run our own, hopefully, genetic lab soon, run our own tests. We have our own donor egg bank. We do a lot of things that we as the physicians can oversee and make sure that everything is done up to, I would say, a really high standard. So I think that at Kindbody, it's very unique, and our mission for everyone at Kindbody is to make sure everyone's taken care of and be an advocate for your care. So I tell patients, if you ever feel like someone's not listening or you feel like your provider isn't necessarily hearing you, then that may mean you need a second opinion. And I support my patients if they ever want to get a second opinion. And I'm always a proponent of somebody being an advocate of your care. And that's certainly one of our strong aspects of our mission too. So what do? We have this broad scope, which I think sets us apart a little bit because we have the options to pretty much do things that are a little bit outside the box, including the things that I said are standard of care, to make sure that everyone is able to build their family how they see it. So we offer IUI, IVF, which we're going to focus the bulk of information on, genetic screening. We have third-party services, which we call family building, which is offering donor sperm, donor egg, gestational carrier. We do men's health. We do all of these things and individualized care because we know everybody's family is unique and how they put that together is unique. And so that's what we're here to coach you through all those pieces. And then obviously tonight, focus on IVF. So our goal is to be on this journey with you. This is one of our physicians who, is down in the Texas location. I said we're located all throughout. And our goal is to give you as much knowledge as you can. And that way you feel super empowered in the journey that you're going through, because it can be stressful. And if we can take out a little bit of that stress by making everyone feel comfortable and knowledgeable, that's what we're here for. Okay, so I start all of my talks with patients in, breaking things down into three big subjects and areas. And it comes back to basic biology and the standpoint, you have to have three big things to have a baby. So you have to have eggs, you have to have a uterus, and you have to have a sperm source. And it doesn't mean you have to certainly have a male partner or female partner. We know that we can use donor sperm, donor egg, gestational carrier, like we talked about, but we do want to investigate these three pieces. And depending on how you put your family together, that'll individualize how these tests come about. So if we know we need eggs, we need uterus, we need a sperm source, we want to individually look at those. So how do we do that? So we focus on the egg a lot. And obviously, if we're looking at someone who's in a same-sex male relationship, we're going to be talking about donor egg. But if we're looking at someone who's coming in and wanting to evaluate any concern for infertility, we're going to start and we're going to look at the egg supply. The biggest thing that changes as we age is our egg numbers go down and the quality of the eggs go down. So we know that for most women, we're born with about 2 to 3 million eggs. Even by the time we reach puberty, we have decreased the amount of eggs we have drastically. And then by the time we reach menopause, we get close down to 0 eggs. And that's why we stop having periods, because we don't have the signaling we need to have regular menstrual cycles. So the fact that our eggs run out, we can do testing to look to see, all right, where do you fall in comparison to someone else? And then this is a good predictor of success rates when you go through IVF. So what are ways to look at your ovarian reserve or your egg health? The first way is a hormone test. So the most helpful hormone is something called an anti-Mullerian hormone. And if anyone's gone through and done some workup, they maybe have already gotten this done. But AMH is, once again, predicting your underlying egg supply. A normal level can fluctuate a lot, and it can definitely be different based on your age group. If we're talking about someone in their early 30s, early to mid 30s, we're going to say that the AMH on average is around 2 nanograms. So someone in their 20s, it's going to be closer to 3 to 4. Someone who's closer to 40, it's going to be closer to 1. So that normal ranges a little bit. Now, once it starts to get below 1, no matter the age, that's concerning to say someone falls into the category of diminished ovarian reserve. Their egg supply is below what is considered normal. Now, people that have really high AMH, sometimes that's indicative of something called polycystic ovary syndrome and can correlate with infertility, harder times ovulating, and potentially affect egg quality. But this gives us a good idea of underlying egg supply. And again, we're going to compare it to other people within that same age group to say what's our level of concern and what's our chance of success in doing IVF. And FSH is another hormone that comes from the brain to tell the ovaries to work. It again gives us more insight into how the ovaries are working. And then an ultrasound. So when we do an ultrasound, we're looking at the uterus, but we're looking at the ovaries to say, all right, how many little follicles try to grow each month? If a wave grows every month, one usually ovulates if you're ovulating and the rest die off. Well, we can do an ultrasound and we can see how many of them try to develop. And that tells us what your underlying egg supply is. So a normal level for somebody in their 30s is going to be an antral follicle count of about 15. Once that number starts to get below 10, certainly below less than 7, we worry about that diminished ovarian reserve. Once it gets really high, again, it can be indicative of that polycystic ovary syndrome. So it gives us a lot of insight into underlying egg supply and our level of urgency, and then our overall chance of success with doing IVF, among other variables. So we talk, like, again, a lot about the egg, and we know that for natural conception, that the egg needs to be picked up by the fallopian tube. Someone in natural conception, the sperm has to make its way all the way into the fallopian tube, fertilize the egg, and then that embryo needs to make its way back into the uterus, have a normal home to be able to implant and to grow. So investigating the uterus and thinking through the fallopian tubes, while the fallopian tubes aren't super important for IVF, the uterus certainly is. So if we're talking about, what has to happen under, natural circumstances, and we talk about that we need the fallopian tube, well, when we're doing IVF, we don't really need that. And so our focus shifts more into thinking about the ovaries and thinking about egg numbers. And so if we focus a little bit on age, and it always feels like people, we're picking on the female partner in a heterosexual relationship, because we know for sperm, that number doesn't really drop drastically. So men can have kids sometimes in their 50s, their 60s, their 70s, because they make new sperm every 80 days. And then we tend to focus a little bit on this mid 30s, this age of 35. And there's no hard and fast change that happens at 35. It's just that we start to see a stronger decline in quantity and quality once we start to get into our mid to late 30s. And that's why we feel a little bit more of an urgency and a push to say, all right, maybe we need to go through things a little bit faster. Maybe we need to talk about egg preservation if someone's not ready to have a baby and they're in their early 30s and moving on to mid to late 30s. So again, there's not a switch, nothing drastically changes, but we know this trajectory is continuing on a downward trend, and it becomes more steep the older we get. So if we're not just, focusing as much on the quantity, we also worry about the quality. So we do these tests, we look at these hormones and the ultrasound, and we say, all right, this is how many eggs you have. This is comparable to someone else. Well, we don't have a good test to look at quality, but we already know that age is closely tied to quality. So once again, when you're in your late 30s, early 40s, even though we don't have a test for it, we know based on data that's been previously looked at that the likelihood of an egg being healthy is much lower the older we are. So when we look at health, we're talking about the fact that an egg may have too many chromosomes or not enough. And this graph shows that, okay, someone less than 35, their likelihood of having an abnormal egg is pretty low. It should be less than 30%. So the majority of the eggs that are being ovulated or potentially retrieved are going to have normal chromosomes. Well, once you start to get into your late 30s and you see this drastic increase in our early 40s, the majority of the eggs have abnormal chromosomes. Because the longer the eggs are in the body, the more stress builds up, and we call this oxidative stress. It makes the machinery that separates chromosomes not work as well. And so you end up with an egg that potentially has an extra chromosome or a missing chromosome. Now, the most likely thing is that that won't fertilize. The next most likely thing is that if it does, it won't implant. And then there's the small possibility that it could implant and miscarry, and a really small chance that it could implant and that embryo could develop to viability. So the takeaway is, as this quality goes down, it just decreases the chance of pregnancy, and ultimately with a pregnancy increases the risk of miscarriage. So it's tough and it's not fair. And we talk about this advanced maternal age, and it doesn't mean someone can't have a baby in their late 30s, their early 40s, or even their mid 40s. It just means we need information. And at that point, we need to start thinking about strategy and think about being more aggressive. And that's how I look at it. Okay. So thinking about the egg, we talk a lot about what the importance of it is. And ovulation and natural conception is very important. And ovulatory dysfunction is one of the most common reasons someone sees a reproductive provider. They're not having regular periods, they're not ovulating regularly. And there's a lot of reasons for that. So we can do tests to focus on the reason, because sometimes you can have underlying health problems related to it. So PCOS, well, that can increase your risk of diabetes or hyperlipidemia. So we want to know about it. Problems with your thyroid or another hormone called prolactin, that can have other medical consequences. Other things called hypothalamic dysfunction, where the signaling is not occurring from your brain to your ovaries, that can also have other implications. And then something called primary ovarian insufficiency, where you really start to run out of eggs before age 40. And if the average age of menopause is 51, it's very abnormal to go through menopause before age 40. And that's indicative usually of some underlying things going on that need to be investigated that then could lead to other health consequences. So this information, these hormone tests, give us a lot of insight into someone's health. And then for our subject matter tonight, certainly gives us information about IVF. All right, so we said the big three components: eggs, uterus, sperm source. So if we've looked at the ovaries, we've evaluated these hormones, well, we want to look at the uterus, because ultimately, if our plan is to transfer an embryo into the uterus, we want to make sure that it's normal. Now, for someone who might be planning a gestational carrier, then we'd be going down that route, working with you from a family building perspective to make that happen. So for the uterus, we can see here that basically the uterus is made up of muscle, and on the inside is the cavity, the endometrium, where a embryo will implant, and that we want to establish and make sure is structurally normal. So that lining that develops, we know that it has to have a cyclical nature of developing and allowing for the thickness of the lining for implantation. And then if you're not pregnant, it needs to shed, because a healthy lining needs to continually develop. If a lining doesn't shed and it's continually getting thicker, the problem is the cells in the lining can become precancerous or cancerous. And they're not a good environment for an embryo, and they certainly can cause health risks as time goes on. So we want to be monitoring, we want to know what the lining looks like. And for someone who doesn't have regular periods, they need to be talking to their physician about concern of that lining, making sure their periods are regular or they're protecting their uterine lining. So once again, tubes, we're not going to be as concerned about. The main issue would be related to if a fallopian tube is dilated and is collecting fluid. So we don't need the tubes for IVF, but we know if fluid is being collected in a tube, it can go back into the cavity of the uterus and it can cause a toxic environment and reduce the success of IVF. So if there is a dilated, large, damaged tube, the typical recommendation is to surgically remove it. So these are things that we're looking for on the ultrasound. A big dilated tube is going to show up as a cystic structure, and it's going to be evaluated and understood whether it needs to be removed. Endometriosis is a very complex thing. We could have a whole night just talking about it. It's something that's always on a reproductive physician's radar to have the possibility of an impact, but not certainly the focus of the conversation for IVF tonight. So this uterine lining, is going to be evaluated at the time of the ultrasound. And again, it needs to have a specific thickness to show that it looks healthy. And then when we start medications to allow for implantation of an embryo, we're tracking to make sure that it's appropriate to allow for proper implantation. So those are the pieces, along with looking at the shape of the cavity and looking at the lining, that are important. So how do we look at the cavity? Well, if we just do a simple ultrasound and we don't put fluid in there, we're not seeing the entirety of the cavity. So the cavity is basically a potential space. If there's no fluid in it, no baby, it's kind of closed down and the layers are compressed. Once you put fluid in it, it will open the cavity and allow you to look for things like polyps or fibroids, which if they're there, they're starting to support the fact that it could decrease pregnancy success. So when we do a saline sonogram, where we put fluid in there, we're trying to look to see if there's anything that would be causing a problem for the cavity that could cause a problem eventually for an embryo transfer. So this is part of that standard workup that we want to do in the beginning to check our boxes to say, all right, we want to get the success rate as high as we can from an IVF perspective, and we want to do all this at once. So if we're looking at the eggs and then we're looking at the uterus here, we're focusing again on different pathologies that could cause a problem, like scar tissue, or some people are born with a shape that is not specifically straight across. And if someone has a heart-shaped uterus, that again can cause a problem. If they have tissue that's coming down in the middle, that can cause a problem. And there's surgical interventions to improve upon that and make the success rates higher. So these are all things that we're looking at the time of doing an ultrasound and making sure the cavity is normal. All right, so the third piece is looking at sperm health. And again, this matters if someone has a male partner. Outside of that, we're going to be talking about donor sperm and the logistics of how that works. For a collection to look at sperm, we typically have someone collect and then evaluate the motility, the concentration, and look through the parameters. The takeaway is you don't need that much sperm to have success with IVF, right? Because you're going to handpick the best sperm in most situations and inject that into an egg. And so you could have success with just a handful of sperm. But recognize if sperm counts are on the lower end, that a lot of times relates to quality, and that may decrease overall fertilization rates. So these are things that we're looking at, because not just do we need a lot of sperm, we want to evaluate in some ways the quality to predict what IVF success is going to be. So this is a helpful marker for that. Other things that we look at sometimes on an individual basis is things like DNA fragmentation, which focuses a little bit more on the quality if we have concerns for that. And there are other things that, from an individual basis that your physician may recommend depending on if there's concern for specifically male factor. So testing that is required for anyone in the United States that's going through and doing IVF is related to what the FDA mandates from us, which is infectious disease, to be able to eventually store embryos, eggs, or sperm. We certainly want to make sure everyone is at their optimal health and looking at hormones. We said thyroid plays a big role, that prolactin, and then making sure that everyone is optimized in a health perspective from pregnancy, making sure they're immune to specific viruses that should lead to an immunity from vaccination. And we get these vaccines when we're young, but not all of us form a strong enough immune response. So we end up having to go forward and potentially get a booster. So genetic carrier screening is recommended by the American College of OBGYN. It's a blood test that we're looking at for the egg source and the sperm source to make sure that they are not carriers of the same recessive traits. We think about cystic fibrosis, smooth muscle atrophy, thalassemia, to where if you're a carrier, you also would have a normal copy. But if the other person also had the same copy as you, there's a 25% chance that a baby could inherit both copies, and that can cause the disease in a baby. And the ones that are tested are things that cause significant morbidities in a, either a newborn or as an infant and a baby. And so these are things that if they're screened for, they potentially could be genetically tested in an embryo to make sure that that condition is not being passed on. So this is recommended for anyone that's planning a pregnancy, not even just by IVF, to understand what your risk is of potentially having a baby that's affected by one of these conditions. Other things that we think about is just overall health, and we talk a lot about BMI, recognizing that once we get to a higher BMI, there's a higher risk of things like miscarriage, preterm delivery, C-section, gestational diabetes, hypertension. And our goal here is just to try to optimize. There's no reason to ever delay treatments or say there's a specific weight that needs to be lost. There's no data to support that. In my practice, my goal is to work alongside somebody if they're not at their optimal weight or health while they're undergoing fertility therapy. And then Zika feels like it's, is Zika even still around? But it is. We talk so much about COVID these days, but thinking about travel and looking at the CDC are things that we also talk about. So nutritional support, things that everyone can do leading up to, any fertility journey, and whether it be IVF, IUI, whatever, is optimizing your vitamin regimen. So prenatal vitamin, I always recommend to everyone, should have at least 400 micrograms of folic acid to reduce the risk of a neural tube defect like spina bifida. And then vitamin D is beneficial. Antioxidants, we're talking about the oxidative stress that builds up in the ovary. So CoQ10 has been shown to be beneficial. And then fish oil with omega-3s have been shown to be beneficial. So individualized, I talk to patients based on if they have PCOS, based on if they have, inflammatory disease, other vitamins, but I think, you can't go wrong with those for anyone that's going down the fertility road. So for anyone that's coming in for a new patient consult, we talk through all of those pieces and ultimately need to get the testing done to get more insight into the diagnosis. But when someone's kind of ready to move forward with treatment, we talk about goals. And that is so important in the beginning. And I'm of the same mindset. It's like, I just wanted to get pregnant and we all want to move forward so quickly, but we also want to take a step back and say, okay, for your family, how many kids do you want to have? Because sometimes that affects what treatment you do. If someone is 38, 40, and they say they want to have 2 or 3 children, well, we may be able to have a pregnancy with natural conception or IUI now, but in 2 years, and then you come back and you're 42, the chance of having that happen is much lower. And even the success of doing IVF is much lower. And so it's kind of planning ahead and saying, well, based on your family size and your goals, we may alter the treatment and be a little bit more aggressive based on that. So I think it's so important to talk through your family size, your age, and the options that could be limiting in the future, depending on what we decide to do now. So for someone, giving a definition of infertility, you never need to wait to meet this definition to start treatment. We classically talk about infertility as someone who is older than 35 if they've been trying for 6 months, and this is in a heterosexual relationship, and so this doesn't even apply to some patients. And for someone who's less than 35, they've been trying for a year, and this is actually super common. I mean, you look at these statistics and you say, wow, it is so common. It's probably even more common than this. But the takeaway for me and what I try to tell patients is you don't ever have to wait to meet that milestone. If you're concerned, if you have irregular periods, if there's something else going on, that needs to be evaluated as soon as you would like it evaluated. All right, so that is the background. I think that was a little long-winded, so I apologize for that. But that is kind of what I would think about as an initial evaluation leading up to the decision to move forward with IVF. This is a picture of actually with me and one of my embryologists in our St. Louis location. We're looking at fertilization and looking at an egg after it's been retrieved and talking about what we're going to do from a fertilization perspective. So the IVF, even though I've been doing it for a long time, is always amazing to me how we can go from this small microscopic egg, then goal obviously is to get to a baby. And that's what we're going to talk about. So how does IVF work? And we can sum it up in a nutshell and then we can go into the details. Basically, I say IVF is trying to mimic a normal menstrual cycle. And if you think about how long it takes to grow a follicle in a natural cycle, on average, it's about 12 to 14 days. So that's how long IVF takes to develop the eggs to then be able to retrieve them. So you think about, you're going to take injections because you're trying to get more eggs to grow, and you're trying to do it for that about 12-day time period that it would normally take one egg to grow. All right. So it feels like people talk about it takes 4 weeks or it takes 6 weeks. Well, that's not true. For most people, it's about a 2-week time period of taking injections, or sometimes less, or sometimes a little bit more, in order to get the eggs to develop. Okay, so how do the injections work? So injections, which they sound very scary, especially for a lot of people, if you're not in healthcare, you've never given injections. I had done a lot of injections for other people, never taken injections for myself. So it still is a hurdle to get past. But I will say, these injections are very small. These are the insulin needles that are incredibly tiny. You pinch your skin, inject these under the skin next to the belly button. So these are the things that we're going to inject for about 10 to 14 days, but you're going to have a lot of coaching before going through this. We have tutorials, we have our nursing staff, we have med teach. Our goal is that everyone feels really confident in going forward and giving themselves these injections. Because when it's you, you want it to be perfect. And we certainly get that. And that's why we're here 24 hours a day. I start taking call at 9 p.m. and I do get a fair share of calls, right? People want to have this done right. And that's what we're here for, to make sure that it is done right. So this is a video that we do. This is just talking about one of the specific injections. So I don't think we have to go into the details, but this is an example of how we would go through the medication, certainly one-on-one, but then the options to have these tutorials for you in case that there's other questions afterwards. We do these weekly med teaches every Monday night. So it's interactive. You can ask questions, you can go through your medications and get all of your questions answered, even leading up to the cycle, which is helpful. The goal is to alleviate as much anxiety as we can, recognizing this is tough and it's anxiety provoking no matter what. So we want to try to mitigate that the best that we can. All right. So then we've gone through, we've taken those injections. We know that the follicles should be growing. We're doing ultrasound every couple days. And we're trying to make sure that once they get to a mature size, which is about 16 to 18 millimeters, we know we're ready to trigger the follicles to mature, and then we're going to go in and do the retrieval. So the retrieval, the goal is to sometimes get 10 to 15 eggs, but this is going to vary drastically, like we said, based on your AMH and your antral follicle count. All right. So for the retrieval, you get conscious sedation. I say this is like a twilight sleep. You're still breathing on your own. You get a little nasal cannula, and you're asleep for about 20 minutes to allow this small needle to go into the ovary and be able to retrieve the egg. So then once the eggs are retrieved, our goal is then to individually pick the best sperm for the most part, inject that into the egg. For the eggs that we retrieve, we expect about 70% of those eggs to fertilize. And then we watch them grow in the lab. So this is one of the really helpful pieces of IVF and why IVF is so successful. One is it bypasses the fallopian tube. Two, you allow for development of the embryo to determine if it's healthy before you transfer it. And then you also have the option to do the genetic testing to, again, look a little bit closer at the chromosomes. So once the embryos have grown for 5 to 7 days, we hope the healthy ones are going to develop to the blastocyst stage, and then we can either transfer the best embryo and freeze the rest. We can biopsy the embryos and wait for the genetic results to come back. Or in some cases, we just freeze the embryos because we know the lining isn't perfect for a transfer, or someone is banking embryos to try to have more for the future in case they're going to come back for a second, third, fourth child. So we talked a little bit, it was a good intro for who asked the question about PGT for recurrent pregnancy loss. So PGT, pre-implantation genetic testing, is an option. It's not mandatory by any means. It's an option for someone to be able to biopsy their embryos after they've developed to that blastocyst stage and look at the chromosomes. So this is a picture here of an embryo after it's developed to that blastocyst stage. And this little pipette is trying to take about 5 cells from the part that will eventually become the placenta. That will be sent off for genetic testing. The embryos never leave Kindbody. And then that information is obtained for the chromosomal number. And for a normal male embryo, we expect it to be 46XY, for a female, 46XX. And if there's an additional or a missing chromosome, that will come back in the report. And for the most part, that's how the readout is. There's some gray in regards to the report, and those are the nuances we get into with patients if there is some gray area in there. The other testing that can be done is something called PGTM. So that's genetic testing for a monogenic condition. And that's if there's a higher risk of, let's say, passing on cystic fibrosis or passing on one of those genes that we're testing for. And then PGTSR is for a structural rearrangement. And that's if someone has a history of balanced translocation. Those are very specific for someone who's already been tested and know they either carry a gene that could be concerning or they have a translocation ahead of time. If you don't have that, when we're talking about biopsy, we're strictly talking about chromosomal assessment because it gets so complicated. But again, this is an option and it makes more sense for patients as they get older. We already said the older we are from a maternal standpoint, we're more likely to have a chromosomal abnormality in an embryo. So this testing becomes more important as we get older. Not to say that younger patients can't do it, because it does give you more information. It can also tell you the gender. So for who is this recommended? To me, it's anyone that wants this testing done. After they've learned about what it does, if you want to do the testing, I think it should be for anyone. Well, who may it benefit more? Well, that recurrent pregnancy loss that we talked about in the beginning, For someone who has potentially had recurrent implantation failure, and we don't have a reason of why the transfers have failed. If they have a history of a genetic condition, like we said, we can screen for. If someone is of older maternal age, because we said that probably has the significant and the biggest benefit. So there's a lot of reasons to do it, and this is individualized. You want to talk through with your provider about, does this make sense for you? The downsides of, PGT, I guess this talks a little bit more about the benefits that we talked about, is that we know that we can obtain the gender. Again, it counts the number of chromosomes, and the accuracy is pretty high, but it's so important to recognize that it's not perfect. And there's, certainly the possibility of having a false positive, false negative, which is typically less than 5%. And so there's still the option to do testing in pregnancy, non-invasive prenatal testing, amniocentesis, CVS, to look at this if there ever was a concern. So the reasons why some people may decide not to do PGT, well, it is a biopsy, so you do have to freeze the embryos while we wait for the results to come back. There's a theoretical risk to the embryo, although we're biopsying the part that will become the placenta, so that risk is typically quoted at less than 1%. And then, one of the biggest things is the expense. And depending on where you are, whether your insurance covers it, which with Kindbody employers, a lot of times we're having coverage for that, which is wonderful because it gives us more information. But if not, then, certainly you want to weigh the risks, the benefits, and the expense. And that's what we're here for, to talk through those pieces. All right. So going back and trying to predict success. And that's what I said. A lot of the information that we get from the beginning is not only telling us more about your health, helping with the diagnosis, it's also predicting success of going through IVF. So when you have an ultrasound done, and I look at your provider looks at your antral follicle counts, those follicles that are growing at the beginning of the month, that's going to tell me potentially how many eggs you're going to have retrieved, and ultimately how many embryos we're going to have to either transfer or biopsy. So if we said someone came in and they had about 12 follicles that develop at the beginning of the month, well, typically about 80% of those follicles are going to give us a mature egg. So I'm going to hope we end up retrieving 10 eggs at the time of an IVF cycle. If the sperm counts are normal, we're going to assume about 70% fertilization rate, which gives us 7 embryos on day 1. Well, we're going to grow these embryos most of the time for about 5 to 7 days to see which ones develop and are healthy. And about a 30-50% time, we're going to see that development happen. So now we end up potentially with 2 to 4 blastocysts. Now, if you're older, we do genetic testing. We said there's a higher chance that it may be chromosomally abnormal. So we could end up with 1, 2, sometimes 0 chromosomally normal embryos. If someone is younger, then they do genetic testing. There's a higher percentage of them that typically would come back normal, which could lead us to have 1, 2, 3, 4 chromosomally normal. And then ultimately, depending on your age, or if someone is advanced maternal age and has done genetic testing, we can predict the success rate of what it would be for a live birth every time we transfer a blastocyst embryo. And that can vary a lot. So as an example, somebody who's in their mid-30s and has not done genetic testing, the chance of a live birth with transferring 1 blastocyst is about 50 to 55%. If you do genetic testing and you're in your mid-30s, late 30s, or even early 40s, and it comes back chromosomally normal, the success is around 60%. Now, if someone's in their 20s, then we know that there's a higher likelihood of success, and their overall success rate is probably around 60 to 65%. So this can vary a lot, once again, based on age and based on genetic testing, which matters a little bit more as someone gets older. So individually, my goal is to give a percentage, and we know statistics are statistics. So we can fall on the higher end of this, we can fall on the lower end of this. And so this is a good predictive model, but it's not perfect. And sometimes we find surprises. And our goal is to be dynamic and have a plan, and then a plan B to our plan, and a plan C, D. And that's always my goal, and certainly what we're here for at Kindbody. All right, so we get the embryos and we make a plan for our transfer. Now, a fresh transfer is saying that we're going to do the transfer 5 days typically after we've done the retrieval. And some embryo transfers are done on day 3, but that's not typically, sorry, my baby's going to bed. So we don't typically do day 3 transfers anymore. Sometimes there's a rationale or a reason for it on an individual basis, but the majority of the time we're growing them to see which ones are going to be developing to the blastocyst stage, because we want to be able to select the best embryo. So a fresh transfer can be done if we decide not to do genetic testing. and if the lining of the uterus looks optimal. Because if the lining doesn't look good or the hormones are elevated, the success rate of a fresh transfer go down. And in that case, we want to go forward with the frozen. And then the reasons why we would, decide to do a frozen from the beginning is if someone's doing genetic testing, or they want to bank embryos to have more for the future, or if the lining, once again, didn't look perfect, or the hormones were elevated and we knew that success rate was lower. A lot of times we're leaning more towards frozen transfers these days, just because many people are opting for genetic testing, and because we want that lining to be at a very optimal place to, allow for that highest success rate. All right, so again, why is, a frozen embryo transfer commonly recommended? It's because of these things: this genetic testing, the, ability to allow for the lining to develop outside of an IVF cycle, and to allow for the hormones to be more physiologic and not as high as what they can be when someone's doing IVF. All right, so this is a little bit busy, but it's just an example of a calendar for someone who is planning to do an embryo transfer. And we would talk you through all of this, so it would make a lot of sense. And I think most people feel really thankful to have a calendar to say, okay, this is the day I'm going to take my medication. This is the day I'm coming in to do an ultrasound to make sure my lining looks perfect. Then I'm going to get instructions to start progesterone, because progesterone is what makes the lining sticky. And then we do the transfer 5 days later. And then we do the pregnancy test about 9 days after that. So this is what an example of what we would get to say, all right, this is what the flow is going to look like. This is the tentative transfer, and this is your tentative pregnancy test when we're going to get that done. So how does the embryo transfer work? This to me is the best part of my job. It should be hopefully one of the easiest. Sometimes it can be a little bit tricky, but that's what we're here for, to solve these problems. So an embryo transfer is similar to a pap smear in the standpoint that we're going to put a small catheter next to the cervix. We're going to thread a little catheter into the cervix, and we're going to deploy the embryo really gently into the middle of the cavity for it to implant. And, it's such a wonderful experience because, obviously the patient's going to be there, their partner, their family member, whoever they want to be there for that experience. We're typically able to watch the embryo come out in the catheter, and then on the ultrasound, watch it go into the uterus. And it's really special. I did a couple today, and they're always special, and certainly one of the highlights of my job. So looking at success rates, and we already said this varies a lot. And one of the biggest variables that causes, changes in success, we said, is related to age. And then the other predictor is going to be related to underlying diagnosis and then underlying egg supply. So this is an example of somebody in their early to mid 30s, so average age of 35. What's the likelihood of success with doing IVF? And this is live birth, so not just pregnancy. What we care about is a take-home baby. And so we're talking about live birth. So for someone at age 35 doing one IVF cycle, the chance of having a live birth is around 50%. If we do the genetic testing and we have a chromosomally normal embryo, we know that success rate is going to be higher, and it's going to be closer to that 60 to 65%. Now, if you look at someone in their 20s, these successes are going to be a little bit higher. Someone in their late 30s, early 40s, these success rates are going to go down. And you can see that here. So you look at IVF success for 35 compared to 41. Well, at one IVF cycle, a 35-year-old, the success is closer to 45%, as opposed to someone who's 41, that success is going to go down. So you look at that and you say, okay, well, what does that mean for me? Well, it means, we want to try to be more proactive and do a cycle sooner rather than later. Someone who's advanced maternal age, we want to have more urgency. We want to be more proactive, and we want to be realistic to say it could take more than one cycle to have success. And so that's kind of how we want to break it down and think about overall you as an individual and what your success rate is going to look like. So again, with it being individualized, we know that this path is not straight. Not everyone is going to do the same protocol, have the same plan for a frozen transfer. Not everyone's going to do PGT. It needs to be very individualized because success rates are individualized. And to have the best success, it needs to be based on you as an individual, what your diagnosis is, and the medication that you're going to get. So this is super important. That's what we're here for. And the goal is to have very strong support for everyone and recognize that it's not just the physical support, the information, it's also the psychological support. And I think that's one thing that sets us apart and makes us unique, is that we have that aspect here at Kindbody, and that's definitely what we're here for. So we said other things outside of thinking about traditional IVF is thinking about what we would say is family building, and looking at things like donor sperm, donor egg, and gestational carrier or surrogates. And we have a specific, part of Kindbody that is dedicated to doing this. We have our in-house donor bank to help with that. And so however anyone's family is built, we're going to be here to help make it happen. So from someone that's using, let's say, a donor, we know that there's options in regards to if there's a known donor, or I would say the majority of patients, probably about 90–95% of patients, go the either anonymous route or non-identified donor. And we will help you get set up with a bank and be able to have that sent to your Kindbody location. For an egg donor, we're so lucky to have our in-house bank. We call it EOS, Kind EOS, to where we can help match you and allow, be there to help you select someone that makes sense for your family from an egg donation perspective. And then also for embryo donation. So patients that have already completed their family, they can donate their embryos, and then that may make sense for you and your family to adopt an embryo and make a plan for that for your family. Gestational carrier, for anybody that has either an underlying medical condition or certainly needs a gestational carrier for the pregnancy, then that's what we're here to help with. We have an in-house bank for that as well. And then we also work with a lot of other agencies to coordinate and make that happen. So I don't think I can stress this enough. There's not one specific way to build a family, and we have all of these things in place to try to make it individualized, to be able to help someone who is maybe needing something that's unique and something that's innovative and outside of the box. Staying evidence-based, but also having that aspect in place is what makes somebody have the best success possible. So next steps, for those that are thinking about moving forward, we know the first thing to do is to try to understand a little bit more about someone's fertility or their underlying egg supply or their health with those tests that we talked about in the beginning, and then going forward and individualizing the protocol for someone who's ready to do IVF. So where is a Kindbody location? I know our focus on this is for the St. Louis region, which is where I am, and closer to the Southern Illinois, and then also for the Arkansas location where I'm going to be in Bentonville. But there are clinics all throughout the United States, and this is just now. In the next year, we're probably going to have, a lot more than this even. And so if you have a question about where you need to go, what your closest location here is, we've got people that can help with that. And as Sydney said at the beginning, they're doing a special promotion through the end of the year for people that don't have insurance coverage to be able to get 20% off their IVF treatment. And so we're here to help someone get scheduled, help somebody get started. And obviously any questions specifically about that, we're here to answer that. Okay, so I feel like I moved a little bit quickly, but it's 7:50, so not too bad.
Oh, you're perfect.
I think we can get, yeah, it's not too bad. So I think if we can open it up to some questions, but Sydney, I don't know if you had anything else that you wanted to talk about before we jumped into some questions.
No, I think you just about covered it, and we will be sending a follow-up email tomorrow with the recording of this session and all the information you need on the promotion as well. And if you do have a benefit with Kindbody, the likelihood is that you do have this cycle covered. So if you do need help navigating that, just email employeebenefits@kindbody.com and they can help navigate through that with you. And then lastly, if you know you're ready to get started and you want to get in before the end of the year, we can have our patient care navigators call you tomorrow. So if you are interested in getting right in, there will be a survey when we end this session. There will be a survey that comes up on your screen. You just have to put in your name, your phone number, and the city that you're living in. And our navigators will call you right away and get you right in. So that is a little bonus for joining this session. And with that, let's go ahead and ask Dr. Purdy some of your questions. Okay, so first, Dr. Purdy, my partner and I will be out of town for a couple of months, but I don't want to miss, my partner will be out of town for a couple of months, but I don't want to miss out on those months for trying to conceive while he's gone. What are some options for assistance in this scenario?
Yeah, that's a good question. So we know we've got busy lives, people travel a lot. So, one of the big options for that would be to freeze sperm. And someone can come in, give a sample, and depending on how good the sample is, sometimes you can freeze multiple vials in just one collection. And then the options for that would be, while they're gone, is to do intrauterine insemination, so IUI, or to go forward with doing IVF. So it probably makes the most sense if someone's going to be out of town and they don't want to miss that time period.
Great, thank you.
Uh-huh.
And here's another question we got, and which we hear all the time. Does PGT, and we did touch on this a little bit, but I just want to get maybe a little bit more in depth. Does PGT affect the embryo at all? When you do biopsy that embryo for PGT, does that affect the embryo negatively in any way?
That's a good question. So we did talk about it a little bit. The risk that we would typically quote based on the studies we have, knowing that PGT has been around for quite some time, the risk to the embryo is probably less than 1% in regards to the ability of the embryo to survive the thaw after it's been biopsied and frozen. We're biopsying, we said, about 5 cells out of about 200, and we're taking it from the part that's going to become the placenta. And that's why that risk to the embryo is significantly low, but we can never say zero. And so from the data we have, I would say it's less than 1%. But it's one of the things that we, take into consideration, knowing that we want to balance the benefits, risks of doing it, but overall is very low.
Great. Thank you so much. Okay, next question. This is coming from a patient. She is saying that she's having a hard time getting her embryos to grow to day 5 blast.
Yeah.
They're on their 3rd round. Is this normal that each one, she's not getting many to day 5? Is there anything she can do for her to, with her own body to keep more of the embryos growing longer?
That's hard so if I have a patient who has embryo arresting before it makes to the blastocyst stage, I always want to go back and look at the diagnosis and see, okay, is there more likely to be an egg quality issue or a sperm quality issue? Now, if someone has underlying, diagnoses like PCOS, where we know that can have an impact on the egg quality, then I would want to change some things in the protocol and look at things like adding in growth hormone. Think about maybe even reducing some of the other hormones down to see if I can improve the quality of the eggs that are developing. If there's more concern for a sperm quality aspect, there are things that have been developed that potentially filter the sperm on a little bit more of a specific basis. It's called zymo. So we think about doing that. And then, outside of that, addressing both sides, egg quality, sperm quality, we sometimes look at doing a transfer on day 3. This is the one area and the one patient population that I think about to consider doing a day 3 transfer. We don't necessarily know, is the uterus a little bit of a better environment than culture conditions? And so if we transfer an embryo on day 3, it's possible for some, more fragile eggs or fragile embryos, they may do a little bit better in the uterus as opposed to in the culture dish. And so that's one of the things that I've, done and had success with doing. So I think there's multiple things to go back and talk through in regards to the protocol to see if there can be improvement in regards to egg quality, sperm quality. And then ultimately, one of the options would be to think about doing a day 3 transfer.
Great. Thank you so much.
Yep.
This is a question we get all the time again. And sometimes there really is no good answer, but I'm going to let you go for that. What are the reasons that implantation can fail?
So the most common reason an implantation fails is related to the embryo. Now, if an embryo is not genetically tested, then that even makes that chance even higher, given the fact that we said age correlates with the likelihood of having a chromosomal abnormality in embryo. But even at a young age, the most likely thing is that that embryo didn't have the correct number of chromosomes, so it didn't keep dividing and it couldn't implant. Now, even if someone's had PGT, we say, okay, well, then it can't be the embryo, but that's not true. There are other structural things that can happen that doesn't allow the embryo to keep developing. And so if it's been genetically tested, it's still a high chance that that embryo wasn't normal or not structurally normal to be able to keep growing. Now, other things outside of that, and we don't want to always just say, okay, it's the embryo and not focus on other things. Well, it could be something with the uterus. And there are things to look at in regards to that, especially if someone's had multiple failed attempts. So something like inflammation in the uterus, which we call endometritis, can be looked for and potentially treated if it's there. If someone has damaged fallopian tubes and they're dilated and they're collecting that fluid we talked about, that can go back in the uterus and not allow for implantation. So a tubal evaluation can be helpful. So there are things to look at in regards to the uterus, and that's typically what I would recommend doing if there's been several failed attempts. And then if someone hasn't had genetic testing, an option would be, if there are embryos left, to consider testing them to get more information to say, all right, are these more likely because they're chromosomally abnormal, or if they're genetically tested, then that is less likely. So I think there's a lot of pieces to look at, embryo being probably the primary focus, but outside of that, things to look at in regards to the uterine cavity as well.
Amazing. Thank you so much.
Mhm.
I'm going to give you two more. So the first one is, if somebody has an irregular cycle, so they're not ovulating monthly, how would this affect an IVF treatment?
That's a good question. So depending on the diagnosis of why, so we'd want to start out and look at these hormones to see, all right, is this related to PCOS? Is this because of the thyroid? Is this because of the prolactin? Because if there's something wrong with your thyroid, well, that can affect the ability of follicles to grow even in an IVF cycle and affect implantation. Same thing with elevated prolactin. And then for PCOS, we know there's increased inflammation in the ovaries. There can be an impact on quality. And so that can affect the ability of the follicles to grow and the maturity of the eggs and potentially the quality. So the underlying diagnosis matters more than the actual anovulation aspect. Because when you're doing IVF, you can manipulate the ovaries to develop follicles, even if you're not developing them on your own, because that's what those injections do, right? You're injecting them, that information's going straight to the ovary to develop these follicles, and you're not necessarily worried about how your brain is telling your ovaries to work. So again, it's more the underlying diagnosis and the impact it could have on the health and the development of the eggs compared to the actual concern for anovulation or irregular ovulation.
Great, thank you. And one more question, then I will just dive back into the 20% promo just to clarify a little bit.
Yeah.
So for someone who is doing embryo banking and would like to do PGT, would that be done after each retrieval, or would that be done once a sufficient number of embryos are retrieved?
That's a good question. I mean, both are options. We typically recommend doing a biopsy after each embryo development, each cohort, because the problem is if you freeze an embryo without biopsying it, and you, let's say, go through 3 cycles, and let's say you end up with, 8 embryos total. Well, then you have to go back and thaw the embryos that were frozen, biopsy them, freeze them, and then when you come back to do a transfer, you have to thaw it again. So that is 2 freeze and thaw processes, which that puts extra stress on the embryo. And the risk of the embryo not surviving is probably about 5 to 7% if it has to go through multiple thaw and freeze processes compared to if it only has to do it once. So for the most part, we typically recommend biopsying in that, fresh embryo development, freezing, getting that genetic information back, and then going into another cycle, doing the same thing. Sometimes from a cost perspective, that can be frustrating, especially if you're paying for the biopsy each time. And so some people do go the route of making all the embryos and then thawing and biopsying in the end. And sometimes that makes sense for a specific patient. The main risk is just related to the concern for overall survival of having to go through those 2 processes.
Wonderful. Thank you so much. And we might get cut off here because it's about to be 9, I guess 8 o'clock in Central.
Yeah.
But if anyone has any questions for the promotion, there will be an email in your inbox tomorrow morning with every detail you need, all the fine print. But it is for self-pay patients and for new cycles only. And thank you so much, Dr. Purdy. We're so grateful to have you here. And thank you so much for such an engaged audience with such amazing questions. We are so excited to see you all, and keep coming back.
Yeah, no, I thank you everyone for coming on tonight. I'm obviously very passionate about this and certainly happy to see anybody in the clinic. And if you have questions, get them to Sydney or get them to me through my Instagram, because I'm happy to answer any of those.
Thanks, guys. We'll end it now. And if you do want to start treatment, there will be a survey when we close this window, and you just have to put in your information and you will get a call back tomorrow or the next day. Thanks so much, everyone.
Have a good night, guys. Bye.